Mike Gibson, Shamir Mehta coming to you live from TCT 2025, and we're talking about the intracoronary administration of tPA in people with a large thrombus burden. It's kind of funny to come all the way full circle in this whole area. It all started with intracoronary streptokinase administration, now coming back to intracoronary tPA administration. Shamir, what do you do and what do you find?
So, Mike, we were interested in studying this question. Um, Microvascular obstruction is obviously the single most important limitation of primary PCI. And over the years, we've had a lot of therapies that have tried to overcome this. Mechanical thrombectomy was used. Two large trials showed it didn't work. Intracoronary 2B3A inhibitors also did not work. And there have been a whole host of other pharmacologic therapies that didn't work. And remember, we had all these trials of facilitated PCI where either full dose or half dose lytic was given to patients before they got to the cath lab. And those trials also failed. So, we thought perhaps if we could administer the thrombolytic directly into the coronary artery, targeting the microcirculation directly, using a delivery catheter, we might be able to show a benefit of this strategy. So we did a randomized trial where we randomized patients to receive two doses of alteplase, 10 milligrams or 20 milligrams, delivered directly into the coronary circulation with a delivery catheter versus placebo. It was a randomized double-blind placebo-controlled study.
And what did you find?
Well, our primary outcome was a composite of microvascular obstruction. We looked at microvascular obstruction in a number of ways. The method that you essentially invented, the TIMI blush grade, which I don't know how many years ago was that, Mike? It's still used. It's
Yeah.
commonly used and probably the most validated method of looking at microvascular obstruction. So we looked at microvascular obstruction in an angiographic core lab, looking at myocardial blush grade. And then we looked at a totally different way of looking at microvascular obstruction. We looked at ST segment resolution as well at 30 minutes, which was done in the in the ECG core lab at the University of Alberta in the Vigor Center. And we combined that with distal embolization, which is easy to identify on coronary angiography. And we also included major adverse cardiovascular events. And the results were completely neutral. And we could not have had a more neutral trial. The combined doses of alteplase versus placebo, the hazard ratio or the relative risk was 1.00. We looked at a 10 milligram dose of alteplase and a 20 milligram dose, and there was no dose response that we saw. Both of the results with both of those doses were completely neutral.
And tell me again how this was done. So the artery was occluded. You put the microcatheter across. You didn't pre-dilate. You didn't send
No, we
anything.
did. We
Oh,
did.
you
We had
did.
to
Okay.
have, yeah, we had to establish antegrade perfusion
Okay.
first, and there had to be good antegrade perfusion that was established
Okay.
prior to, so that was the first thing. So they came in with primary PCI. It had to be a large one.
Mm-hmm.
Small STEMIs were excluded from the trial. So it had to be large anterior or large inferior with a total of 8 millimeters of ST segment deviation. They had to have a large thrombus burden. If they didn't have a large thrombus burden, if they had normal flow at the very beginning, they were excluded. So they had to have a large myocardial blush, myocardial thrombus grade of 3 or more.
Mm-hmm.
And 90% plus had 4 or 5. So large thrombus, large infarcts, primary PCI, we established antegrade flow, and then we introduced a microcatheter, and the drug was administered through that over a period of about 3 minutes. And then we carried on with primary PCI as usual. We gave high
Yeah.
dose heparin. Most of the patients had high intensity P2Y12 inhibitor with ticagrelor or prasugrel. And then we looked at the outcomes of
Yeah.
microvascular obstruction.
Well, another great hypothesis shot down by the data. We thought
It
we,
takes a lot of years to do these trials,
yeah,
Mike. This
yeah,
trial
yeah.
went on, it started before COVID. A lot of people involved. How these trials are done, and a lot of pain. And but we found the answer. It is not this for microvascular obstruction, and that's why
That's
we do
it.
trials.
Well, the microvasculature remains undefeated. That's all I gotta say. It's still
Yeah.
searching. Yeah.
We're still searching, and the whole question is why. I mean, you raised the issue earlier of myocardial hemorrhage. Are we inducing myocardial hemorrhage by giving a lytic? Even though we only used 10 or 20% of the systemic dose, it was a much smaller dose that we gave. When you look at the
Locally,
volume of
it's 1,000 times higher. If you give it in that small volume, it's 1,000 times higher than systemically, right?
exactly, yeah, the volume of distribution is so much smaller
Yeah.
that you're getting a very, very high level within the coronary microvasculature. So
Any
was it
harms?
myocardial hemorrhage?
Yeah. Any harms when you did this?
When we were injecting the study drug, there were more episodes of VF in the alteplase group versus the placebo group. It didn't quite reach significance, but it was definitely higher. The p-value was
Yeah.
0.06.
Yeah.
And likely it was because of too vigorous of an injection of the tPA into the microcirculation compared with the placebo. Alternatively, it could have been some other property of tPA. It could have been the viscosity. It could have been the pH.
The
Could have been
pH.
the
Yeah.
it could have been the solvent. The solvent is not saline, right? The solvent is sterile water for
Yeah.
tPA. So it could
Yeah.
have been that. Something irritated the myocardium.
Yeah.
All cases were defibrillated successfully. There were no cardiac deaths as a result of that. So it didn't really seem to have a lasting impact. But again, another issue suggesting that this is not a recommended therapy.
Yeah. I didn't see any benefit with TNK. I mean, it's a very, very, very small study. I think there's some UK data that didn't achieve significance. This is kind of another study showing that we didn't really improve things. But this is why we do research, right?
Sorry, yeah, that's where we do research.
Yeah.
This is number three now. So there was your trial, the ICE-T study with TNK, and there was the fairly large T-time trial, big multi-center trial
Yeah.
in the UK.
Yeah.
And that was also neutral. And this is now number three, showing a neutral trial. There is one more that's ongoing in Australia called the Restore MI trial, looking at a similar question with TNK, and they're giving the drug after stenting. They're stenting and then administering the drug to patients with high IMR. So there is one more trial that's ongoing, but it's not looking good.
Yeah. Not looking good. All right. Well, I know how hard these trials are to do, and to enroll that many people and answer the question definitively was amazing. Great work, man. Well, thanks for joining us here today. And thanks for all of you for joining us here live from TCT 2025.